Welcome to Knowledge on the Go, the podcast brought to you by the PI programs team at Vizient. Across the country, healthcare organizations are working to make interhospital transfer smoother and more consistent for patients and care teams. Dr. Benjamin Buettner, Assistant Clinical Professor of Internal Medicine and Medical Director of the Transfer Center for the Ohio State University Wexner Medical Center, joins us to discuss this important topic. I'm Shannon Hale with the PI programs team at Vizient and your host. Dr. Buettner, welcome and thanks for joining us.
Hi, Shannon. Thank you so much for having me. Please call me Ben.
Will do. I'm looking forward to the conversation. Could you tell us a little bit about your transfer center at the Ohio State University Wexner Medical Center?
Our transfer center is a very busy place. Our name is a little bit of a misnomer because the name only reflects just one aspect of the work that our team does 24/7, 365. Our transfer center team is responsible for all patients who are being referred from a referring hospital, coordinating their service acceptance and bed assignment and bringing them to our medical center. Our transfer center staff touches each and every single bed request from the emergency department, patients who are being direct admitted, patients being admitted after the OR, coordinating movements into and out of the ICU. Capacity management is the other significant arm of day-to-day work. About 25% of all admissions to Ohio State originate at another hospital and then are transferred to us. Overall, for our entire group of work our transfer center does, they touch about between 8,000 and 8,800 unique bed requests each and every month. Our team has 42 staff members in total. We have one manager, 3 leads who over the last year we've transitioned to a more 24/7 lead presence throughout the entirety of the day, 32 nurses and 7 bed placement coordinators. We start at 7 a.m. with roughly between 5 and 7 staff members. We up staff as the day goes on at 10 a.m. and 1 p.m. to account for the influx of calls that we see during those hours. And that demand really continues until about 1 or 2 a.m. where we start to taper off staff a little bit. We do dedicate staff who are only doing calls at one time so that we can really streamline that efficient process for getting our patients from other hospitals accepted.
Wow, you weren't kidding when you said it was busy. We just completed a 6-month collaborative here at Vizient, and it was focused on interhospital transfers. One of the areas that organizations are working on is standardization of the transfer process, whether that's acceptance templates, the same process is occurring regardless of the referring or the accepting clinician. Have you worked on something like these different processes at your organization? And are there any insights that you could share around it?
We've done a lot of work on this at Ohio State. To start off, just a little bit of detail about the way our academic medical center is structured. It really is helpful to understand the why and the how. OSU is somewhat unique as an academic medical center in that we only have 2 inpatient locations. We have our main campus, roughly 1,300 beds, and then we have our smaller community academic hospital just 5 miles down the road, OSU East Hospital. We have about 211 beds there, or roughly 16% of our overall system capacity. Our team is very busy managing inpatient beds. When we looked at how do we make things more standardized, consistency is so crucial. This is a very critical time in a patient's illness journey, and there's many things that can go wrong, opportunities for delays, things that get missed, continuity of care. This very dynamic aspect of the patient's illness journey is structured internally for our providers at OSU, that when they're on call and it's the middle of the night and our transfer center is reaching out to them, that they get a similar experience each time, similar information, patients following the process. When we looked at how could we do better, what opportunities did we have in our transfer center, we really recognized giving our frontline staff the support to do their job, make it easy to do the right thing consistently every single time. About 2 years ago now, started our innovation project called Enhanced Transfer Triage, the consistency and the structure around these interhospital transfers. Our phase 1 was really about ensuring we're bringing that right patient selection. Phase 2 was about the right place and the right time, and we did a lot of internal work from a system flow perspective. Our phase 3 of the work is doing all of that in conjunction with our key service lines. Our key service lines can't grow transfers without us, and we can't grow transfers without them. One aspect in phase 1 we did to bring a lot of consistency was in what our transfer reason was for the patient. Previously, when a patient was coming, we would assign them one of 12 different transfer reasons. There was a lot of ambiguity, a lot of interpretation about what one reason meant versus another, and a lot of overlap. They were very inconsistently used. We now assign one of 4 transfer reasons. Each of them has a clearly delineated acuity difference from one to another. So at the very top are all of our time critical disease programs, trauma, stroke, vascular emergencies. Then we have our transplant patients coming for a higher level of care need, and our lateral transfers. We have different expectations for those different groups of people. And for lateral transfers, it really allows us to make a decision for that patient on whether we're going to accept them that's reflective of what our capacity is at that point. Some of the other work that we've done internally within our electronic health record, every aspect of our team's job is within our EMR. And the way that it's structured reflects the natural cadence of how these triage conversations typically go. We have nurses on the phones with our providers, and it's really important to me that we do everything we can to support them so that they're working to the highest level of their license as expert triagists and as nurses. Anything we can do to offload some of that burden of documentation, it's great for our team. When we began a lot of this work, we knew that we would need a lot of internal stakeholder buy-in. We launched a transfer center case conference. What we've done in that case conference is we bring a case. Sometimes it's a case to highlight a new process. Sometimes it's to highlight a difficult clinical scenario that came up. Sometimes it's to highlight a customer service opportunity on the phone. This meeting is attended by some of our most senior leaders at Ohio State. It's been a great venue to collect and collate a lot of information from a lot of people who have different expertise, roles, lines of sight to understand how can we be better? How can we serve the referring providers and the patients that they serve better and more consistently?
You hit on so many things there. Optimizing your electronic health record for patient transfers, buy-in, whether that's from your executive team or your frontline, so important. You mentioned when you first started speaking about how critical of a time this is. Sometimes we know that, but sometimes that gets a little lost in the translation. And there's a reason you're being transferred. We need to be reminded of that.
I've heard other leaders say, how can we get to yes? Sometimes yes is not the right answer, though. Sometimes because of system capacity, we are not doing anybody any favors by saying yes to patients that we never realistically are going to be able to deliver a bed in the time that they're going to need it. We would queue up a really long wait list, sometimes several days for patients. It's important for us to be accepting patients that we are uniquely qualified to care for that they cannot get at the local hospital. But it's really those lateral transfers. There are patients who want to be under our care. There are providers who want their patients under our care, patients who have been seen here before, familiar with us. And at the end of the day, even if there is not something that is concrete, if a provider feels that they are uncomfortable, they don't have the resources that they need for the patient, the patient-centric thing to do is to figure out how to accommodate that patient, but to still ensure we're taking care of our internal patients and not doing so at the jeopardy of our overall patient flow.
As you think about your work with the Transfer Center, is there one top achievement that you are most proud of there?
For me, the processes that we've put into place that have been focused on investing in the clinical expertise of our frontline staff. That is fundamental in a well-functioning transfer center, that we give them the tools to do their job consistently and well. Our transfer center nurses know some of the ins and outs and how to navigate these patients through the system better than some of our very seasoned providers here at Ohio State. It's what they live and breathe every single day. We went from an average of about 120 completed transfers a month to East to 150. We've had multiple record-breaking months since then. It's been a sustained trend. One month we got as high as 175, which is the highest that we ever saw there. And not only did that help flow across the enterprise. It helped OSU East. Keeping their beds filled and working gives them license to ask for more resources, more services. The patients get excellent care there. The more patients we got there, the more likely it would be that we would bring somebody to East, and then at some point during their hospital stay would subsequently need to go to Maine. And we decided that we would need to tolerate a small amount of that increase. Obviously, a huge amount was going to be counterproductive. And a very happy surprise when we did the analysis, we were actually having less of that while still arriving more transfers. And the reason why we invested in a resource to allow our nurses to use their judgment and their clinical expertise. Providers always help our nurses out. Our nurses are able to engage a provider from any service line. During one of our transfer center case conferences, somebody said, "Hey, Ben, we have all of this technology linkage with some of our existing hospital partners. Is there a way to make it easier?" Doctors would wait on hold. At the top of the call, sometimes 4 or 5 minutes of exchanging name, date of birth, demographic information, callback number. We at Ohio State have some non-Ohio State hospitals, very important partners that actually utilize our instance of our electronic medical record. And we decided, let's leverage that technology linkage. Those conversations, Shannon, I will tell you, are night and day difference compared to before. It's because our nurse is able to look at the chart, see what's there, and go into that conversation much more targeted, focused on the nuances and the clinical story and less on this information gathering and data entry while on the phone with the provider. It's because they have the opportunity to digest things ahead of time rather than getting it live in the moment. Those conversations are much more informed and have really allowed our nurses to work to the top of their license to be the expert triages.
Those are great insights. It's leading me to my next question. We've polled organizations and asked them where they are in the process of optimizing their inter-hospital transfer patients. We know that there's a lot of organizations out there that are just starting to look at how do we best optimize this entire process. Based on your work, are there any lessons learned that you would voice to those that may be listening now?
One of the possible pitfalls in looking at interhospital transfers is to take something that's been identified as an opportunity and try to fix it in isolation. This is an incredibly dynamic and complex process to get a patient from one hospital to another. A really important exercise that I did was I sat down and I wrote down every single step that it takes. I'm talking like granular steps, picking up the phone, waiting on hold, exchanging basic information, exchanging clinical information, all of those steps. And I looked at them. Each of those steps is necessary. We can't delete one of them. But what of those are value added and what are not value added? What can we do to make each of those better? And that's going to require a lot of institution support. It requires a lot of willingness to look at multiple projects at the same time. You define your KPIs, you do your data analysis, and you're happy for a period of time. But what does that look 6 months down the road? What does it look like a year down the road? You really have to think about ingraining that into the culture of the frontline staff. It's one thing for us leaders to be excited about something. You have to have the frontline staff who's there for his or her 12-hour shift that day to really have this part of their natural workflow for it to be sustained 1, 2, 3 years down. This looks different depending upon that transfer reason, that acuity, but anything we can do to streamline that is going to be impactful. We were able to decrease that time by about 34 minutes on average, about 13% overall. That was a victory in that portion of the whole process. We were able to decrease the average turnaround time by about 113 minutes or 28% overall. Transport is still one of the largest unmodifiable aspects. It's getting better. It's largely outside of our direct control. But as we get better in the aspects leading up to that, transport is now making up a larger percentage. About 80% of that time improvement was related to things that we did directly in our own processes. We know there are going to be times where our bed availability is lower than average. It's going to take longer to get a patient a bed. We know that there are going to be times where there's higher than average call volumes. When you take a multifaceted approach, you can build in some tolerance for some of those natural ebbs and flows that you're never going to be able to predict and still make the process better because you've looked across the entire spectrum.
So phenomenal work. You've done a lot there and you're seeing some great results. You spoke on a recent collaborative webinar about this work. So I've heard a lot about what you're doing there. I'm interested to ask you, what's next?
This next year, it's all about collaboration and calibration. We've laid a foundation that really allows us to look and analyze our performance. A few of the key things we're looking at are time-critical diseases. We get those patients accepted and brought here as timely as possible. A large portion of my work over the next year is to go to those service lines that represent these time-critical diseases and taking a look at our algorithms for triage of these patients and ensuring that the process works for our transfer center nurses and works for their service lines so that we can streamline those patients as much as possible and to have alignment. We have a lot of emphasis on our cancer population, our neuro population, and our emergency general surgery population. What we're doing in the transfer center and what they are doing on their service line are aligned. We can't improve transfer volumes for those service lines in isolation. We need to work together, and technology and electronic methods to improving things is really exciting for me. Leveraging any upcoming electronic health record tools is something that's like top of my mind at all times. There's a lot of cool AI predictive analytics, capacity dashboards. How are we going to utilize it and how are we going to manage its success? So simply having a really cool capacity dashboard that people look at, that's not going to be impactful. So it's taking that stuff and ingraining it in the day-to-day, minute-to-minute work of our frontline staff. One thing that's got me thinking a lot is ambient AI listening to help providers with note generation. I think it'd be tremendously fundamental for our nursing staff. And again, how do we offload that burden of documentation? Having ambient AI listening to help with some of that would be really important. It was striking how much nuance and good information is exchanged on those call recordings that never makes it into the intake for anybody to look at. I don't think there is a single admitting doctor out there who wants to step away from the patient to go listen to a call recording. The reason that stuff doesn't make it into the intake log is because our nurses, they're great. They're not stenographers. It's really going to help our nurses. It's going to be, from a patient safety perspective, a lot of really useful information going out into the ether.
Ben, thank you so much for joining us today and talking with us around this important work. We know this is an area where a lot of organizations are struggling, so I'm certain that these insights that you've shared today are really going to benefit a lot of people. And thanks to you, our listeners. Please join us for more knowledge on the go. Subscribe today, like us, and send us your comments at picollaboratives@vizientinc.com.